labor that is painless, that's when the doctor wants to know if you want to go ahead with an epidural or you want to go ahead with a normal labor and experience the pain. All right. So before we start the before we start the lecture, I want you to know why epidural is important for the guys and the girls. Girls, you are going to have to take it sometime if you want to, which is a good option. You might have a painless labor. And for the guys, in case your wife comes and asks you if I should go ahead with an epidural or not, you should have an idea as to what you're going to say to her, right? So, if I can have a little bit of attention, maybe the guys and the girls later on in a few years might need the epidural anesthesia for yourself or for your loved ones. All right. So, let's start. We'll start with the anatomy of the epidural space. Okay, epidural space or peridural space or extradural space. Okay, it's given three names: epidural, peridural, extradural. It is a space that lies between the spinal meninges and the sides of the vertebral canal. It is a potential space. It is also called a negative space because there is negative pressure inside. Sorry. So yeah, now here you can see this is not a good picture actually. Uh, yeah, yeah. So here, from here you enter the this part is the skin part. Okay, this is the bone. This is your posterior. From here you enter into the skin. This is where your needle enters. So the layers that the needle transfers during epidural anesthesia when you're giving in spinal, I think you've been mentioned the layers of the spinal anesthesia, right? What are the layers that cross? You first enter into the skin, then subcutaneous fascia, then supraspinous ligament, and interspinous ligament, and then the ligamentum flavum, and then the dura. Okay, so the difference between spinal anesthesia and epidural anesthesia is in spinal you enter into the dura and into the spinal canal. Into the CSF you inject the drug. Whereas in epidural, you just stop at the ligamentum flavum. Which is the previous slide. Okay, how do we go back to the previous? Yeah. You can see the ligamentum flavum here. Once you pierce the needle into the ligamentum flavum, here is the epidural space. This is your epidural space. It consists of fats and blood vessels and lymphatics. This is where you inject the drug. All right, and this is the dura mater. You enter, the needle enters from here, like this, into the epidural space here. Once you cross the epidural space and cut through the dura mater and the arachnoid, then you are into the cerebrospinal fluid. This is where you give the spinal. This is where you give your epidural. Clear? Okay. So the epidural space is the potential space between periosteum lining. See, this is the periosteal lining of the vertebral body and the spinal dura mater. All right. It extends from the foramen magnum. This is from top to bottom. It extends from the foramen magnum to the sacral hiatus and surrounds the dura mater anteriorly, laterally, and posteriorly. It is a semilunar kind of space. Okay. And throughout, it is surrounded by the dura mater. Is someone saying something? Am I not able to hear or something?
No, ma'am.
All right. Okay, now coming to the boundaries of the epidural space. Cranially, it is covered by the foramen magnum. The cranial boundary is foramen magnum, caudally by the sacrococcygeal ligament and the sacral hiatus. Anteriorly by posterior longitudinal ligament. Laterally by vertebral pedicles and intervertebral foramina. Let me show you the previous slide. You can see that. So here cranially, top, anyway you can't like anteriorly by posterior longitudinal ligament. Here you will have the posterior longitudinal ligament anteriorly, then laterally by vertebral pedicles and intervertebral foramina. These are the pedicles here. And posteriorly by ligamentum flavum. Here you will have the ligamentum flavum, where you are crossing through, that is the last layer of the epidural space that needle enters. Now contents. Contents in the epidural space are all areolar connective tissue, fat, spinal nerve roots with their neural sheaths, blood vessels, spinal arteries and venous plexus. The venous plexus are called Batson's plexus. And then there are lymphatics. Here there's a cross section of the whole spinal canal. These are the, so this is going to be your back. This is your back. Here you'll have the skin, subcutaneous fascia and all. Then the supraspinous ligament. All right. Then there is the interspinous ligament. Then you have the ligamentum flavum. Then you enter the epidural space. This is your dura and arachnoid. And this is your spinal canal with the CSF and the spinal cord swimming in it. All right. So this is where your needle enters. This is your spot. You feel for the spinous processes. And you enter in between two spinous processes like this. Cut through the supraspinous ligament, then interspinous ligament, then ligamentum flavum, and then you are into the epidural space. Okay, this is just a picture of the Batson's plexus. That is the contents of the epidural space. Now, now the whole vertebral column, okay. Let's just talk about the anatomy. So there are 24 individual vertebrae. Okay, why I'm mentioning 24 individual vertebrae is because rest of them are fused, the sacral and the coccyx. So there are 24 individual vertebrae, which include 7 cervical, 12 thoracic and 5 lumbar. And then the 5 sacral fused vertebrae and the coccyx. Now, vertebral anatomy varies according to each level. The atlas and axis are highly atypical because they don't look like the rest of the vertebral bones. Like they don't have the body and pedicle and lamina and kind of thing. So they're little atypical comparatively. Now, atlas and axis anatomy are relevant to anesthetists in that the odontoid process of the axis should be closely applied to the anterior arch of the atlas in flexion and extension. Anyway, that is like not important right now. But from C3 onwards, the vertebrae all look the same. You can at least recognize the body and the pedicle, lamina and all. So, why is it important is because at each level, at cervical level, at upper thoracic level and the lower thoracic level, the space that the epidural space takes up is different. So, when the needle enters, you are calculating the number of centimeters it has gone inside. So, at each level, the number of centimeters keeps changing. So, that's how it helps you in deciding where to stop. Because if you enter a little more, you might puncture the dura, which might lead to a spinal anesthesia. And we don't want that. Because spinal anesthesia needle is really thin. So even if it like punctures, it will not be much of an issue. With spinal anesthesia, we enter the dura because the needle is very thin. But the epidural needle is comparatively thicker. So if you manage to, by chance or by mistake or whatever, if you just enter into dura with a epidural space, there are high chances that the CSF might leak. So you don't want that. That is a complication. One of the complications of epidural anesthesia is that you might enter and puncture the dura. So you don't want that. You want to be low or level. So that is the reason why the distance between the skin and the space is important. So in the anterior region, it is almost non-existent because this is a semilunar space. In the anterior, it almost is negligible. Whereas when it comes to the posterior part, the space is increasing. Posterior part of the canal I'm talking about. Are you guys following me?
Yes, ma'am.
Okay. So at the cervical level, the epidural space is 1 millimeter to 1.5 millimeters. At upper thoracic level, 2.5 millimeters to 3 millimeters. At lower thoracic level, 4 millimeters to 5 millimeters, and at lumbar level, 5 millimeters to 6 millimeters. So now what do you understand from this? At lumbar level, it is the easiest to get into because you have so much space. You can manipulate a little bit more. And the toughest is at cervical level because the space is like really less. You have to be technically very advanced to do a epidural in cervical. Okay, now how to reach the epidural space? I think I've just explained to you guys while explaining the anatomy how to reach the epidural space. And so first you get through the skin and subcutaneous tissues, then supraspinous ligament, internal. You guys need to know this on tips. Like you have to, if I wake you up in the midnight, you should be able to tell me the layers of the, when you're giving an epidural, what are the layers that you have to cut through, and when you're giving a spinal, what are the layers you have to cut through. You need to know that. It's really important. Again, it's the same thing. Same thing. This is spinal cord. This is the epidural space. This is your dura. So between dura and the ligamentum flavum is your epidural space. Okay. This is where you are entering from. Skin, then supraspinous ligament, interspinous ligament, then the ligamentum flavum. All right. Now, what are the advantages of epidural anesthesia? Here, you rapidly achieve surgical analgesia. It's the same as that you've seen in spinal anesthesia. Okay, you can, in spinal anesthesia, it is more of anesthesia, like you have sensory and motor blockade both. Whereas in epidural, you can limit to just analgesia. There is no motor blockade. Now, why is it important? Can someone tell me why is it important that we need to have just analgesia and no motor blockade? Why do you not want a motor blockade, and why do you just want analgesia? Why is it more important? Why is it better than spinal anesthesia? Someone through chat or through audio, whatever is. Okay, I can't find my chat now. Where is it? Okay, just audio. Someone, please. Yes or no? If you at least know the answer, just say yes or no, whatever. No?
No, ma'am.
Okay. So, analgesia is better than anesthesia because in anesthesia, when there is motor blockade, you cannot walk. When you have taken a spinal anesthesia, you cannot walk. With an epidural, you have an advantage that you can still walk without feeling any pain. That is the reason why it is the most sought option during labor analgesia. The woman can still walk and she can have an epidural and still deliver a baby. Okay. Now, limited motor block. Like I just said, the motor block is very limited. Reduction in stress response. Again, when the patient is more mobile, when the patient can still feel the legs and walk around, the patient is less stressed out compared to general anesthesia or spinal anesthesia where they're paralyzed. The least depressant, alert participating patient. Again, the same as that, because you're not completely bedridden and stuff, the patient is more participating and patient understands, patient is aware as to what is going on. So less depressing effects. Now extend the duration to match duration of procedure post-op. So what you can do with epidural, this is a very good advantage that you are given epidural and the catheter is placed in your epidural space, and that catheter can be continued post-operatively also. So in case in spinal anesthesia, you just give a drug and then you cannot repeat the procedure again. Epidural gives you an advantage of having a catheter, and you can give multiple doses of the drug and continue the procedure for as long as the surgery goes on. Sometimes the surgery, you don't expect it to go for more than 3 to 4 hours. But in case if the circumstances turn bad or something and the surgery gets prolonged, in spinal anesthesia, the effect wears off. So you'll have to convert that procedure into a general anesthesia. But in epidural, because you have a catheter, you can increase the number of doses. You can give one more top up and continue the procedure. That is one advantage. And the other advantage is, even if the procedure is done, you can use it as a post-operative analgesia. With the catheter on, you can shift the patient to the post-operative ICU, and then You can continue top-up doses every few hours, and the patient will not feel any pain, and the recovery will be better. Again, psychologically also, patient is a lot more better. They don't have those mental issues and stuff later on. Recovery definitely will be better than the ones without epidural. Because with pain, also there are a lot of complications. People cannot breathe properly. That will lead to respiratory issues. So yeah, epidural that way provides a lot of advantages. Okay. So contraindications are absolute and relative. Absolute contraindications. First one is patient refusal. If patient is not agreeing to go ahead with the epidural, you cannot do anything about it. You just have to listen to the patient. Then coagulopathy. Can someone tell me why coagulopathy is an issue? Okay. So yeah, you're injecting a drug. You're piercing through the skin and the other layers of the patient. So obviously, you want the patient to be normal with no coagulable abnormalities and stuff, because that might lead to bleeding issues and bleeding disorders and stuff. The platelets should not be less than 50,000. Sorry, 5. What is this? 5 lakh. Okay, platelets should not be less than 50,000 when you're giving a epidural, because again that will lead to bleeding. Now, infection at the needle site also is a problem. You cannot give an epidural when there is an infection at the needle site. And severe hypovolemia, because these drugs, final anesthesia and epidural and all, they all cause hypotension anyway. So with hypovolemia, they might lead into other issues. Then relative are severe cardiac disease, aortic stenosis, and Eisenmenger syndrome and all. Neurological disease, you cannot give in spina bifida and all. Then increased intracranial pressure, you cannot give an epidural or a spinal. So this is your epidural set. This is how it looks. So this is the epidural needle. It has a stylet and a needle, and there is a loss of resistance syringe, and there is a catheter with a filter. This is the filter, this is the catheter. All right. And these are just the extra additional needles and connections and stuff. This is your epidural needle. It is called a Tuohy needle. Tuohy. Tuohy needle. And it has abrasions on it. Like you can see these are 1 centimeter each. This helps you in deciding how many centimeters you have gone inside the patient. And with each level, how many centimeters you're supposed to go and how many centimeters not. Okay, so this is your needle. This is a stylet hub. This is a needle hub. This is the wing. It has a sheath and a cannula and a stylet. Okay, this is the loss of resistance syringe. I'll tell you why it is called as loss of resistance syringe. And then there is a filter. This is the catheter which you'll put in and leave. This is like it is left inside the patient for at least, depending if you want to continue with the post-operative. But it helps you in giving the top-up doses. It has radio-opaque lines in case you enter completely and leave the catheter inside, or if the catheter breaks and it's left inside the epidural space, it will help you detect it with a X-ray or something. Now, there are different types of epidural anesthesia. There is traditional epidural, low dose epidural, walking epidurals, patient controlled epidural, continuous epidural infusion, and combined spinal epidural. All right. Now, traditional epidurals, you use either 0.25% or 0.5% of bupivacaine. Bupivacaine is a local anesthetic that you use. In this, you get a proper motor block and a sensory block. All right. Here, this is what you use in spinal also. But with this dose, you get a motor block. This is not just for analgesia. This is proper anesthesia. Now, low dose epidurals. This is with using 0.125% bupivacaine. In this, there is more patient satisfaction because the pain relief is really good, but there will be mild motor weakness. Not complete motor weakness, but there will be mild weakness. And then we have walking epidurals. Walking epidurals are the one that we use for lower labor analgesia. These are very frequently used these days in most of the obstetric practicing. They use 0.06 to 5% bupivacaine with or without fentanyl. There is high degree of maternal satisfaction because the patient cannot feel any pain at all. That is the most stressing part of a labor. And if you can get away with it, nothing better than that. So, yeah, for the girls and guys out there, this is why you should know about epidural. Even otherwise, you have to know about epidural, but I'm just trying to get your attention here by telling you the thing that is most important. You might need it in the next few years. So high degree of maternal satisfaction, no motor weakness, and low incidence of cesarean section if used for labor analgesia. The reason why it is called walking epidural, can anyone tell me? Why is it called walking epidural? Just common sense?
Because the patient can walk.
Yeah, okay. Okay, so there's one more thing with epidurals. See, epidural is something, you should be thankful to science for it. It is an amazing thing because it has also given you an option of, in case you are the patient and you've been given an epidural, you can self-regulate your drugs. Like you can decide how much of pain is good for you and how much is not, how much you can handle. So that way, the dose of the drug can be reduced. So this is where patient control epidural anesthesia is very much helpful. The patient can, depending on their level of tolerance of the pain, can decide how much of the dose they want. Normally what we do is, otherwise we just decide a dose for the patient and give it off. It could be less, it could be more. If it is less, obviously the patient will tell that he's still feeling the pain and then you can give more. But still, if you're giving more, it is not good for the patient, although the effect will be good. So in this, what you can do is you can avoid higher doses. So advantages are flexibility and benefit of self-administration, ability to minimize drug dosage, reduced demand on professional time. Yeah, this is also one of the very good things. You don't have to be there to give them the dose all the time. You can just explain. Obviously, this needs a lot of explaining and stuff to the patient. They might just take up more drug. I understand that, but still, the doctor doesn't have to be there all the time to keep giving doses and assess and stuff. The patient can themselves assess it, and you can just put a technician there or a nurse there, and they can handle the rest of the thing. The doctor doesn't have to be available all the time. Disadvantages: it may provide uneven block. Like we said, if in case we need a more block or something, they might not be able to do it. We'll have to again interfere. Addition of a basal infusion provides more even block, greater metal satisfaction, low dose. Now, you could either ask the patient to adjust the dose, or you can put an infusion pump and let the dose go on its own. Like, set a basic dose and let the infusion go on over a continuous period of time so that the block remains even, so that there are no higher and lower doses. What happens is when you have given a dose and when the effect wears off, there is that gap between the effect wearing off and you be giving a next dose. With the infusions, you maintain that continuous effect, which is a very one advantage of giving infusions. So this is a more even and greater metal satisfaction and also lower dose requirement than continuous infusion. Now, combined spinal epidural. There is also a technique which includes a spinal and an epidural. Okay, where you can give both spinal and epidural, because from the last class that you've attended, I'm sure you've understood the spinal and epidural anesthesia. The technique is almost the same. You enter from the same place, like this same anatomy part and all that is almost the same. So you can give a spinal and epidural both. How do you do that is, you get sets, like you have seen the epidural set. There are epidural sets which are combined spinal epidural sets, where you can first enter through the epidural needle, give a spinal through that needle only, then come out and then push in a catheter and leave the catheter in the epidural space. Okay, so now the idea behind the combined spinal epidural is reduction of some of the disadvantages of spinal and epidural anesthesia while preserving their advantages. Okay, like what are the disadvantages of spinal that you can achieve with epidural? Spinal, you're just giving one dose and you cannot repeat the dose. It's done. With epidural, you can continue the doses. Okay, so once you've given a spinal, because the spinal has a better relaxing effect, motor blockade and all that, you can have the advantage of spinal and epidural both. Then advantages: rapid onset of analgesia, reliable, fewer failed or patchy blocks. There is no with epidural, you have a disadvantage of maybe you will get a patchy block. So when you're giving a spinal and epidural together, you are ruling out this thing. There is no patchy block at all. With spinal, you will cover the operative part, and with epidural, you can cover the post-operative part. Now, effective sacral analgesia in advanced labor, like we said earlier. Then less motor blockade and better patient satisfaction. Now, disadvantages are: the catheter may go through the hole made in the dura mater by the spinal needle. Right? It is expected when you're trying to give both combined spinal and epidural. Maybe your catheter that was supposed to be in epidural might enter the dura. Then metaparticles contamination when inserting the spinal needle through the epidural needle. Very unusual, but yeah, because you're using the same play point of injection, also through epidural giving spinal, maybe some metal particles might contaminate. Then the anesthetic may leak into the subarachnoid space. This is also very common. It could happen. Then dilution and enhanced spread of epidural drugs by CSF. Because you're giving it into spinal, in case it goes higher up, and probably the drug from the epidural has diffused into the CSF. That's when this happens. Then difficult handling. It is again technical manipulation and stuff is required. You need to be technically well equipped and stuff to do a combined spinal epidural. Not that it is difficult, but obviously bit more difficult than doing just a spinal or just an epidural. Okay. Technique. If you're doing an epidural and spinal separately, like there are sets that give you both combined spinal epidural, and if in case they don't give you if your setup doesn't have a combined spinal epidural set, you'll have to give an epidural separately and a spinal procedure separately. So you give a spinal anesthesia at L3 L4 level, and you look for a epidural one space above it. Okay, and then single segment needle through needle. This is that kit wala thing. First step, पहले spinal anesthesia दे दो. Then second one, placement of epidural catheter. This one is single segment is through a combined spinal epidural kit. Otherwise, this is, if you don't have a kit, you're doing it in two separate techniques. You're giving an epidural and you're giving a spinal separately. Complications of epidural is, okay, first we'll talk about safety. No maternal deaths in 26,000, very low incidence of complications. Okay, it is considerably safe, but there are still complications which are immediate. You'll have nausea, hypotension. These have been discussed earlier in spinal anesthesia and all this. Nausea, hypotension, total spinal anesthesia, hypoventilation, subdural injection, failure to relieve pain. Then intravascular injection. Yeah, this is also possible that you entered a vessel somewhere and injected, and then there is systemic local anesthetic toxicity. This is like an immediate, like big time complication. Then there are nerve injuries, not instant in onset. Yeah, epidural is not very instant. You'll have to wait. Spinal anesthesia is instant. You can see it like 30 seconds or something. The patient starts telling you, I can feel tingling and stuff. But in epidural, you'll have to wait for at least 5 to 10 minutes. Then maybe associated with motor blockade. You don't want a motor blockade, but there are still chances that there could be motor blockade. Then there is urinary retention and pruritus. Again, like these are like allergy and rashes and stuff. Late postdural puncture headache. This also has been discussed earlier. Epidural hematoma, epidural abscess, and backache. Backache is a very controversial topic. A lot of people have said that post epidural they have had backaches and stuff. I'm not really sure how much it matters, or if there is any theory to back it up. But personally, I don't think it is related to backache. Probably if you have done multiple punctures or something, probably it could lead to backache, but I don't think with a single puncture it would be possible. Okay, thank you guys. We're done here with the epidural. We finished quite early. Okay, so yeah. Okay, Adil Khan asks me, ma'am, how can we be sure that we are in epidural space and have not crossed the... Okay, So if you're in epidural space, okay, good question. Actually, we missed this part. Okay, if you're in epidural space, how do you know whether you're in epidural space? We haven't spoke about the loss of resistance syringe. You have given a loss of resistance syringe with the epidural set. In spinal, I'll just tell you a basic difference first. When you're entering spinal into the CSF, your needle, once you pull out your stylet, you can see the CSF dropping from your needle. That's how you know you're in the spinal space. In epidural, you don't feel anything of that sort. There is no CSF in epidural space, right? So you cannot see any CSF dropping from this needle. But in epidural, what you do is you put a, let me go back to that slide where you can see the set once again. Yeah, see, this is your loss of resistance syringe. This is your needle. So you attach this syringe to the needle, piche, and then you enter into the skin. So you slowly keep pushing the what you should do is in this loss of resistance syringe, you should fill at least 2 ml of air and attach it to the needle and then enter the skin and start pushing the syringe. You're trying to push the air inside the needle, but until you reach the epidural space, you will not be able to push the air inside because you're facing resistance through the skin, ligaments, and all. You will not be able to push the air in. But once you enter the epidural space, because it is a negative space, like I told you earlier, the moment you enter, the plunger will go in. The syringe ka plunger will go in. You will see a sudden loss of resistance. Do you understand? Who was that? Who asked that question? I forgot your name. Wait 1 minute. Adil. This is Adil. Okay, where did this chat go? Okay, Adil, just like unmute and tell me if you understood. I can't find the. Hello, guys. Someone tell me you understood.
Ma'am.
Okay.
Ma'am, one doubt, ma'am.
Yeah.
What is the length of the needle in the epidural, ma'am?
It's almost, I think, 9 centimeters. Yeah.
Okay, ma'am. Thank you.